right. Well, good afternoon or good morning, depending where you are. Welcome to this week's Crisis Jam. I am Lindsay Browning, Director of Medicaid Programming at the National Association of Medicaid Directors, and I will be your host today. We are thrilled to have a great featured presentation teed up from Jolie Long on state compacts. So really excited to get into that conversation in a little bit. But first, as always, we want to jump in with some updates, some reminders for all of you. As always, you can find the latest resources from the Crisis Jam on talk.crisisnow.com. This includes the materials, the PowerPoint slides from these weekly calls, as well as the YouTube channel that has recordings of recent featured presentations, including the conversation, I believe it was last week, on current events impacting LGBTQIA individuals. Next slide. We are continuing to seek your great ideas for speakers and topics to feature on the Crisis Jam. We've had over 400 unique speakers since the Crisis Jam launched in 2020. We are always looking for your great ideas, particularly thought leaders and experts in spaces where we haven't had as much conversation as a community. So please send those ideas in using the link that's in the chat. Next slide. So let's jump into some news articles from this week. The first is a news article from WYPR about Maryland lawmakers passing a bill to permanently fund the 988 hotline. And I'm actually going to invite Daniel Rabbit, who's the policy director at Behavioral Health Systems Baltimore, to jump in and just offer a few quick reflections on the news article and this development in Maryland.
Sure, thanks, Lindsay. Hi, everyone. We've been working on permanently funding 988 in Maryland for a number of years. We have a campaign, it's called the Fund Maryland 988 campaign, that has a standalone website and has developed branded materials and social media content. And so this is really the culmination of all that work. Our legislative session ended a week and a half ago, and we were able to pass a 25 cents per month per line 988 telecom fee in Maryland. We expect the governor to sign it in the next couple weeks. And so we're really thrilled to be in that position and to see over $25 million coming into the state for our 988 trust fund starting next fiscal year. So it's very exciting. This article came about kind of because of the ongoing work that we have been doing. This isn't the first article we've had in NPR, a local NPR. We also did a number of articles around the 1-year anniversary for 988 back in July of 2023 and at the launch. And so we kind of cultivated these relationships both in the Baltimore area and in the DC media market. And so passing the legislation was just another opportunity to both highlight the importance of 988, remind the public of the value the 988 offers, but also to kind of commemorate this victory and just a stronger and more robust 988 and crisis system to come. So really happy to see it. There's a couple other articles that came out around the same time as well, and we're hoping to get a few more when the bill gets signed next month.
That's great. Thank you so much for sharing, and congrats.
Yeah, thank you.
Our next news article is about some of the changes that are being experienced by 911 call center staffers. Particularly, the call center staffers are struggling with being understaffed, but also this reality that the job has gotten a little more complex and harder as call center responders are not only sort of deploying EMS and police, but also now mobile crisis services as well. So it's a great article to check out, and the link to that one is in the chat as well. And then our final article this week is about how the 988 hotline has revamped some of callers' experience. I think folks have probably heard some reports around callers' challenges as they wait on hold. So just featuring this article features some of the improvements that have been made to respond to that customer experience. Next slide. Want to remind folks that June is coming up quickly, going to be here before we know it. So if you are interested in attending the Zero Suicide Summit, the Global Leadership Exchange, or the Crisis Now Summit in Europe, make those plans ASAP. I know that there's going to be a great set of convenings and hope to see many of you all there. I will not be there, but I know this community will be. I will be on maternity leave. All right. We want to turn to our crisis trivia hot seat. And this week, we don't have one person in the hot seat. We have all of you in the hot seat, all 152 of you. And we want to ask a question that relates to our feature topic today, which is the Counseling Compact. So the Counseling Compact will allow professional counselors licensed and residing in a compact member state the privilege to practice in other compact member states. This privilege to practice will and is intended to promote ease of mobility and ensure increased continuity of care. So we want to hear from you all on this question. We'll pull that up. Which of the following has not enacted legislation to be a member of the Counseling Compact? Is it A, Louisiana, B, Hawaii, C, Iowa, or D, South Dakota? So we got to see what the audience says. You guys are all in the hot seat today. Give you a couple more seconds to respond. I know I have not been following this issue closely, and in our pre-meeting in advance of this, I definitely got this question wrong, but I bet you guys will do better than I did. All right, let's see what you said. Ooh, you all are a little bit split. Looks like South Dakota is coming out as the slight favorite of the group. But let's turn and see what the correct answer is. Next slide. All right, the correct answer is actually Hawaii. So a lot of us got it wrong today, again, myself included. So Hawaii has filed legislation to be a member of the compact, but it hasn't been enacted yet. And according to counselingcompact.org, which is tracking that state legislation, the states that are currently members include Louisiana, Iowa, and South Dakota. So those three are already part of the compact. All right, next slide. All right, well, now we are going to turn to our featured presentation, and really thrilled to invite Jolie Long to share with us today. Jolie is the Legislative Research Manager in the Government Affairs and Legislative Affairs Department at the National Board for Certified Counselors. She has worked in this space for quite some time and is the former Executive Director of the American Association of State Counseling Boards as well. So Jolie, we're thrilled to have you here today to share with us sort of the state of play around the Counseling Compact.
Wonderful. Thank you so much, Lindsay. I really appreciate that. Hello to everyone. Thank you for having me here today to share a little bit about an exciting occurrence in the counseling field. And as Lindsay said, my name is Jolie Long, and I work as the Legislative Research Manager at the National Board for Certified Counselors. And I am a counselor myself, and have been working with NBCC for quite a number of years. So I've seen the profession go through many changes and progression. So I'm really happy to be here today to talk to you about the compact. Next. Today, I am going to be talking about the compact, as I said, but I first wanted to share a little bit of information about NBCC for those that may not be familiar. We do work with many of the organizations that are on the call, and our practitioners work in various mental health settings. NBCC is a not-for-profit. We're an organization that was created in 1982. And we are the largest credentialing organization in the United States, and our numbers have been steadily increasing since 1982. We're happy to say that. We currently have around 74,000 national certified counselors. Through certification, we set the standards for the counseling profession. We like to say that we're counselors working on behalf of counselors. Our certifications are focused on education, examination, supervised experience, and adherence to ethical guidelines and practice. NBCC also created and maintains the licensure exam for the counseling profession that's used by all of the states and in all the jurisdictions of the United States. And our main goal is to advance health equity and to expand access to quality mental health services in the US and across the globe. We also have 2 affiliate organizations, and those are the Center for Credentialing and Education and the NBCC Foundation, and they help us achieve our mission and vision as well. Next. I also thought it might be best to define and describe who counselors are, just to make sure we're all on the same page with that. Of course, counselors are primary mental health providers. We do assess, diagnose, and treat the symptoms of mental health conditions and disorders. We have graduate level education, supervised experience, and we're licensed to practice at the state level. Counselors work in a variety of locations with a wide variety of populations, often in underserved areas. Now, in terms of payment, it is important to note that all public and private payers or insurances recognize counselors. And for those of you that may not know, counselors and MFTs are the newest mental health providers that have been added to the Medicare system as of January 1st. Sorry, I got a little choked up on that. We've been working on Medicare for quite some time in the profession, so it's really quite exciting that counselors and MFTs are now included in that system. Next. Now let's jump into the compact and what a compact is. And compacts in general are legislatively enacted and legally binding contracts between states, and they're applicable across various policy areas. They often solve problems between states, and they're becoming increasingly used in occupational licensure. The compact is one portability model, and of course there are others like reciprocity and universal licensure, but the counseling profession has now settled after a number of years on the compact, and it's moving quite swiftly. Universal licensure and reciprocity agreements obviously are still in place. Those don't necessarily compete with the compact, but can work in conjunction with the compact. Next. So why is occupational licensure, why are they important? And there are a lot of reasons why they are important. We have a very mobile society, much more so than ever. So that lends itself to the compact. We also have telehealth and many other technological advances that make this a great option for the counseling profession. In addition, compacts can increase access to care, which is what this is really all about. So in that way, it increases access to all areas of the United States, since practitioners can serve clients across state lines. And this can help ease the workforce issue shortage problem that has become even more apparent during and following the pandemic. They're also very military friendly in that they provide provisions for service members and their families as well. Next. So the counseling compact is a mutual recognition model, and it authorizes both in-person and telehealth practice for those who hold an unrestricted license in a member state to practice on what is called a privilege to practice. So it functions much like other occupational compacts that you may be familiar with, and addresses the demand for counseling services, and it aids when counselors move, and then it can expedite the licensure process for them if they move to another state. The counseling compact process actually began back in 2019 with a joint effort between the American Counseling Association and the National Center for Interstate Compacts. As of this month, the Counseling Compact has 34 member states, and my organization, NBCC, is one of 4 ex officio members, along with the other major counseling organizations such as the American Counseling Association, the American Mental Health Counselors Association, and the American Association for State Counseling Boards. Next. Here you will see a map of the current member states. It also shows the states where there's pending legislation. So the dark blue states are the ones that have joined the compacts already and passed legislation. There are around, I think, maybe 8 other states with current legislation. But as another one of the speakers said a few minutes ago, some of those sessions are coming to an end. Of course, we're getting close to things coming to an end for the legislative sessions. But 34 is a big number, and it's moved really swiftly. If you want to look at this map, you can go to counselingcompact.org, and they do keep this up to date because legislation obviously is moving swiftly. So that is the map there. Next. So licensure boards and state agencies can benefit from the compact, and here are some reasons why. It allows the state to preserve and maintain its own licensure system while also retaining the scope of practice in each state. In other words, the compact does not attempt to control the state. The state still maintains its processes for single state licensure. It also forges relationships and cooperation among the states and allows regulation across the states, which has been something that has been missing in the counseling profession. And one way this happens is through a shared interstate database that contains disciplinary information. So that can be easily and quickly shared among the compact states, whereas that is something that has also been missing in the counseling profession. Next. In terms of benefits to practitioners, this is something that practitioners have been requesting for a really long time. And the question is, how can we easily practice across state lines? And how can I easily transfer my license if I happen to move to another state? And because we live in such a mobile society, this is an issue that's been going on, but is even more so now. So if you happen to live in a compact member state and you move to another compact state, then you are in luck because you can get licensed very easily when you move to that other state. So basically, it authorizes licensees who practice in their home state to practice in what is referred to as a remote state. That is one of the privileges. It also improves licensure portability by expediting that process if you do relocate. It also reduces the effort needed to maintain individual state license and also the cost that it reduces the cost of maintaining multiple individual state licenses. It takes advantage of the new telehealth opportunities and also enables active duty military personnel or their spouses to practice. Next. There are also consumer benefits that go along with this, in that it increases access to services in general. It also allows a client to find a specialty practitioner that may not be available in their state. So this allows them to the consumer to cast a wider net if they're looking for something in particular in terms of a specialty practitioner. It also improves continuity of care in that a practitioner can continue to work with a client that moves to another compact member state, or if they're going to be in another state temporarily for work or for school or for some other reason, that the practitioner could continue to see them And that's without the time and expense that it would take to go through gaining a license in every state that your clients may be visiting or may be residing in. Next. The states do have certain requirements that they must meet to become part of the compact, and they are listed here. It's things like they must license counselors, they must require a national examination to become licensed. They must also require 60 hours of education and supervised postgraduate experience. In addition, the state must have a way to investigate complaints and unethical behavior and have a way of reporting that as well, because that information will have to be shared in the larger compact commission data system. Next. In addition, there are also practitioner requirements. So you have your state requirements to be in the compact, and then there are also practitioner requirements as well, and you will see those listed here. Your home state must be a compact member. And I want to point out too, you must reside in your home state. That is what you have to reside in the home state, and your state must be a compact member. You also have to have an NPI number or social security number, no adverse actions against your license. You do have to participate in the FBI background check. And this is a big one because not all states require that as part of licensure. So this is a place where state licensure boards are having to maybe make some changes to accommodate so that their practitioners would be eligible as well to be in the compact. You have to adhere to the scope of practice. You have to comply with your home state's continuing education. And this is something that's been a big question too, because practitioners want to know, do I have to do continuing education requirements for every state where I gain a privilege? And the answer to that is no. You only have to comply with the continuing education credits or requirements that are in your home state. Practitioners will be required to take a jurisprudence exam in every state that they apply to take it to get a privilege to practice. So that will be an additional requirement if that state that you're trying to get a privilege in requires a jurisprudence examination. So a privilege to practice is considered equivalent to, it's not a license, but it's considered equivalent to a license. Next. Again, I just want to state how important it is, and I want to point out that the state licensure boards do retain their own scope of practice. They also retain and control the initial licensure process in their state. They do have, if you're a compact member, you will have access to a centralized compact data system. And this really helps to protect the public, which is the main goal of any licensure board. So having access and getting that any kind of unethical behavior that has happened in any of the states that you have a privilege to practice in or the home state, that would be shared across that data system, which is really a benefit of having that data system in place. In terms of the cost, this has been a big question too. What is this going to cost? The commission will charge an administration fee for a privilege to practice. And then the state licensure board is also able to charge an applicant for the privilege. Now, what that state board charges above what that administration fee of the commission will be up to the state, and the state will determine that. So that could range anywhere from zero if a state can support that themselves, or if they need to charge a fee for those administrative fees, they are able to do that as well. Next. So how does the administration of the compact occur? The Interstate Commission implements and administers the compact. So the commission of the compact consists of one voting delegate from each licensing board in a compact state and the 4 ex officio members that I mentioned earlier. The commission must meet at minimum once per year. And then there are also committees that are set up within the commission to do the work as well. Currently, there are 3 committees: the executive the exec the finance committee, and the rules committee are current functioning committees that they meet, I think, on a monthly basis right now. And I also want to point this out too, that the commission functions as a quasi-governmental agency. And that means that they have to post the meetings on their website, post the agenda, and that all of the meetings are open to the public. So if you, as an organization or as a practitioner or just someone that's interested, you can attend all of those counseling commission meetings. And I would encourage you to do that, because that's where they're setting the rules, to implement this counseling compact. There's also going to be a licensure data system, which I've referenced a couple times, and the member state licensure boards will communicate and exchange information with that larger data system. So that would be things like licensure verification, disciplinary actions, those types of things. And the commission is currently in negotiations for a contract to build that system out. So that's where that stands right now. They have hired an executive director and a secretariat. And as I said before, to get the most current information on the compact, you can go to counselingcompact.org. That is the website and where all of the most current information would be. I do want to point out too that there has been support from other organizations to get this off the ground. Organizations such as the Department of Defense has been in support of the compact and has really helped it achieve success and gain the traction that it has so far. Next. I wanted to share just this brief timeline with you to really show you the impact of how swiftly the counseling compact has moved. In 2021, Georgia and Maryland became the first 2 states to adopt the counseling compact. And then in 2022, 15 additional states joined the compact by passing legislation. Now, our counseling compact was activated when the 10th state joined. That was Nebraska in 2022. And so then the commission could be stood up after that. So that happened in 2022. The commission had its first inaugural meeting. And during this meeting, they began drafting the rules and the bylaws and setting up the committees for the structure of the commission. In 2023, 14 additional states joined. They also hired a secretariat for the commission. And then in 2024, they hired an executive director. His name is Greg Searles. And 3 additional states have joined this year, with Arizona being the latest, the 34th state that just passed its legislation last month. So things are moving quickly now. They are working very hard with exploring the data system, trying to get that contract in place to create the data system. That will have to be created and in practice before they can issue any privileges to practice. So previously, they were thinking that they would be doing that by the end of 2024, but since the data system is not quite built yet, they are now saying that they will likely issue the first privileges to practice sometime in 2025. Next. So I know that was a lot of information. I tried to be as concise as possible in sharing it with you, but please feel free to check out the websites for NBCC and also for the compact, where you'll find much more information. Thank you so much for sticking with me. And thanks to this organization, I've learned a lot. This is my first Crisis Jam. So I'm very excited to be here and share this information with you all. Thank you so much for having me.
Thank you so much, Jolie. And before we transition to our roundtable, I wanted to ask you a quick question. I've had a few questions come into the chat around what clinicians are included as part of this, specifically a question around whether licensed and certified addiction counselors would be included in the compact, and or whether psychologists would be covered.
This compact is for counselors. So if you hold a license, if you're a licensed counselor, like an LP, I know it's called different things in different states, but if you are a licensed mental health counselor, a licensed professional counselor, then you would be, you could be considered for the compact. Psychology has its own compact. But in terms of addictions counselors, again, it's going to depend if they are licensed as a counselor in their state.
Super helpful. Like many things in this world, it depends, right?
Unfortunately, yes, that is true.
Wonderful. Well, thank you. Let's go ahead and transition to our roundtable and want to hear some reactions and thoughts on this compact work. So I'm going to invite Jake Jackson, who's the Senior Director of Public Affairs at KPM Group, and Joel Miller, who's Government Relations Consultant at the National Board for Certified Counselors, to jump in. So Jake, would love to go to you first. Just any reflections, reactions on what's happening in this compact space.
Yeah, definitely. Thank you very much for having me. I'm Jake Jackson, Senior Director of Public Affairs at the KPM Group. Work closely with Jolie and Joel to help kind of usher the compact legislation through in various states. So very excited to be here. I think you wanted to touch on kind of how compacts in general, and then how the counseling compact and specifically kind of relates to crisis care and why it's such an important I think tool for crisis care. Obviously everyone on this call knows that there is a massive shortage of mental health professionals in the United States. As of 2023, 160 million Americans live in mental health professional shortage areas as determined by HRSA. We know that already that workforce that we have a shortage of is also already strained, suffers from burnout, and then you add your crisis care on top of that. That's obviously a very difficult job, day in and day out. So they probably tend to suffer burnout at a higher rate. And then kind of what that means for patients is folks that don't have access to mental health care are much more likely to end up needing crisis care, right? Which actually crisis care providers then end up sort of burdening or shouldering the burden of the shortage much more acutely. And so the counseling compact in the states that it's been passed in is hopefully a tool for, as states, localities, the federal government, and then health systems have sort of made crisis care part of the continuum. Many health systems, for example, have sort of integrated crisis care into some emergency room departments. I'm sure obviously all of you know this, but that's really a trend over the last 10, 15 years, which is great. But the flip side of that is we need more crisis care professionals, and that's obviously an issue. So the counseling compact, allowing folks to move seamlessly from one state to the other, will help those systems, will help those states, help those mobile crisis service providers recruit and retain more qualified professionals without those professionals having to go through the licensure process in a neighboring state. And that will hopefully help get more providers into the places they're needed more quickly. And then of course you look at the uptake of telemental health care and sort of the role that it plays here. The compact streamlines that process. So to the extent that there's crisis care being delivered in the telemental health space, that would help counselors that are in compact states to be able to provide those services without having to worry about am I licensed and do I have the appropriate credentials here? And then just one other thing to touch on briefly, there's really some rural aspects and some urban aspects that just wanted to highlight when I'm thinking about I'm here in the DC area, and so obviously it's an example of Virginia, Maryland, DC. Virginia and Maryland are currently members of the compact. DC is not yet, and so when you think about the how often it is folks are traveling from Virginia, from Maryland into DC and vice versa, those urban areas, and you think about a place like New York City as well, with surrounding states, New Jersey, Connecticut, what have you, that makes those sort of dynamics really lend themselves well to a compact. And obviously in your cities, there's much more people, and the crisis care is a huge is kind of the need for it is felt much more acutely. And then, of course, rural populations. Rural states have been some of the first ones to adopt the compact just because they have such a shortage of folks. And I think they've been quick to jump on the train. And I know crisis care in a rural setting is even more difficult. So hopefully this will encourage folks to be able to work in rural populations, which many counselors like to do, but are limited because they feel like they can't. They don't want to go through the licensure process again. So with that, I'll kind of turn it over to Joel to see what his thoughts might be.
Thanks, Jake. Thanks, Jolie, for those presentations, and thanks again to David, Kristen, Karen, and others for inviting us to talk about the Counseling Compact. I'm just going to try to make 4 or 5 key comments here related to the public policy, implications, and play off a little bit from Jolie's and Jake's comments. Occupational licensure interstate compacts like the Counseling Compact, I believe, really provide a novel or unique solution, to address inefficiencies in state licensing processes that may serve as a burden for providers who wish to practice across state lines. So my first comment that I really wanted to highlight is that interstate compacts expand access to care through better licensure efficiencies and improving overall effectiveness, through strategic and collaborative use of the current mental health workforce. And I really want to emphasize the byword here is the current mental health workforce. We're not talking about graduating, more students like, Medicare funded, residency programs, or expanding eligible providers to the Medicare program, like Jolie referenced related to mental health counselors and MFTs. What we're really talking about is, those strategies, of course, are incredibly important as part of the workforce capacity playbook or toolkit, but they're not really aimed at maximizing the current workforce we have in place, through transforming state licensure, especially for people under the age of 65. So really talking about positioning the current workforce. The second point I want to make is that interstate compacts like the Counseling Compact and telemental health are inextricably linked, intertwined. Going forward, reducing federal and state barriers to providing telemental health services across state lines is going to be incredibly important to the success of compacts like the Counseling Compact. The third point I'd like to make is that compacts really benefit the public. And I know that, Jolie and Jake talked about this by improving, access to mental health healthcare services, especially for people in underserved and remote rural areas. The point here is that during, the worst periods of the COVID-19 pandemic, as mental health care systems across the nation were really pushed to the brink, the need for collaborative initiatives, like interstate compacts, really try to ensure a strong, fluid mental health workforce. And that becomes even more apparent in times of crises. And now, as telehealth is certainly gaining more momentum and workforces shortages do continue, it is clear that the need for innovative solutions to facilitate mobility of the current workforce is not going away. The other points I want to make just very quickly is that, compacts go a long way to enable, mental health care continuity and removing, geographic, limitations or barriers. A workforce that adapts is better able to maintain continuity. Care continuity is especially critical for mental health and primary care, where patient-provider relationships should be optimal to maintain care quality. And I think in some of the questions I'm seeing in the chat box, for college students, seasonal workers, snowbirds, it is not uncommon to live in different states and different parts of the year. So the counseling compact and other compacts really help preserve that patient-provider relationship through periods of relocation or dislocation. And the fifth point I want to make is, I believe compacts can improve quality of care. The counseling compact has developed, rigorous criteria with input from national practitioner boards and state licensing boards, and practitioners must meet that criteria to get a compact license. So the compact can really, really helps to enhance public safety by requiring member states to share investigative and disciplinary information and cooperate in investigations of potential misconduct, by practitioners. And from a healthcare equity perspective, it is essential that licensing policy really centers those patients most affected by limited access to care. So just to summarize, interstate compacts are not a complete panacea, for the healthcare workforce crisis, but for now, compacts certainly enhance the capacity of the existing workforce by increasing the reach of practitioners into areas of high need, reducing the strain on healthcare workers in those areas, improving care continuity, mitigating provider supply crises, and enhancing access to care. So again, thank you for this opportunity, and hopefully we've got some time for questions.
Thank you so much. We are a little tight on time, but Joel, Jake, Jolie, I just really appreciate you all sharing your expertise. I know I feel much more informed about the Interstate Compact work and the opportunity it may present to improve access to care. And hopefully we can respond to some of the questions in the chat if that's all right. But I do want to keep us moving to our standing updates and make sure we have plenty of time for those. And would love to invite John to join us for the SAMHSA update. John?
Thanks, Lindsay. I'm going to focus my comments on one major update to let folks know about that SAMHSA yesterday published the Saving Lives in America 90-Day Quality and Services Plan. It's posted on our webpage, and I'm happy to put a link in the chat as well. But this plan is intended to provide a blueprint to continually improve and standardize 90-day suicide and crisis lifeline services across the country. There's a pretty significant section within the plan that clarifies roles, definitions, and sets forth federal requirements across a range of areas, including operations, data, privacy, cybersecurity, training, referrals, quality assurance, and communications. And as I said, does focus quite a bit on different roles that support the Lifeline, including the role of SAMHSA, the role of the Lifeline Administrator, centers, as well as states, territories, and tribes, because we know that increasingly states, either through legislative action or other efforts, have a strong interest in developing and incorporating their own platforms and technologies to support crisis services in a way that works with the 988 Lifeline system. And so this plan is intended to support those opportunities to both set performance expectations and adherence to standards at the national level, while establishing processes to permit flexibilities at the local level in building these crisis networks and systems of care. So really happy that we're able to publish this yesterday. This obviously is an iterative document that we will continue to update at a regular cadence. And as I said, I will put it in the chat for people to take a look at, and then would be happy to answer any questions that people may have about it. And that's it, Lindsay.
Wonderful. Thank you, John. Continuing on the theme of J names today, I'm actually going to turn it next to Dr. Jessica Pollard for the NASHPIT update. So Jessica?
Yeah, Lindsay, you're going to have to change your name. I am Jessica Pollard. I'm a senior behavioral health advisor at NASHPIT. and a clinical psychologist. So I love the timing today of talking about interstate compacts, since literally yesterday my application was approved to practice interjurisdictional telepsychology. So that's in 40, soon to be 42 states and territories. And what I wanted to talk about on the NASHPD update is what I think is a priority for probably everybody on this call. Certainly it's a priority when we speak with state leadership, territorial leadership around the country, is workforce. And we have a variety of resources at NASHPD to try to help with recommendations, suggestions, providing examples across the full spectrum of what can help bolster not just the numbers of the behavioral health workforce, but also the capacity of existing workforce, like we've talked about with compacts. But other examples too, such as how to effectively and appropriately use technology to extend the reach or to supplement the work of, or make more efficient the work of, the behavioral health workforce, and getting rid of, unnecessary administrative burdens. What our Surgeon General has at times called the GROSS acronym, getting rid of stupid stuff, but things that just don't necessarily have to be done by credentialed or trained behavioral health professionals, what things aren't actually necessary. How do we draw more people to the career pathway? So things like marketing and communication, as well as, the traditional strategies we've tried of increasing the number of training opportunities. We also have to draw people to those pathways. And then, as I said, technology solutions. How do we make better use of the time we have? How do we engage more laypersons and paraprofessionals into the work? And so many other examples. And the way that we've distributed those kinds of recommendations and resources is across things like our transformation transfer initiative resources. So we have a learning community, for example, and on workforce. Those are recorded and are posted on our website. So even if you're not on that invitation, you can view all of our workforce communities. I'm going to put links in the chat about those. There are also resource guides, so examples from the states that have been participating in our TTI about what they've tried. We have a workforce resource guide, which is updated periodically and is just full of examples with detail. So if these are things you're interested in implementing, you've got some good examples to build from. I'll mention tomorrow's TTI workforce community, or collaborative rather, is on Georgia's certified peer specialist program, be presented by Dana McCrary of the Georgia Office of Recovery Transformation. And it includes a discussion of the value of peers in crisis response. We've got some other presentations, such as growing and strengthening the behavioral health crisis response workforce from last year's NASHPD annual meeting, and how to improve workforce well-being from our TA coalition. Maybe an oldie, but a goodie, only a year old, our 2023 988 Suicide and Crisis Lifeline Center Workforce Challenges and Barriers, along with recommendations. And you'll be seeing more from us on technology and workforce. So examples, resources, brief articles. So don't hesitate, if you're a state or territory, to reach out to us. I'll put my email along with the links in the chat if you'd like to brainstorm with us about what your workforce efforts are in your state. What we love to do is compile examples from those of us who have been in behavioral health commissioner roles, who work for NASHPD, but also what we hear from all the state and territory leaders from around the country. We always shamelessly steal your ideas and share them with others, of course, giving proper credit. So don't hesitate to reach out to us. And I'll just end with a teaser that we are, hopefully soon, SAMHSA will release the Behavioral Health Workforce Guidance Manual, which is extensive recommendations across the continuum of workforce around everything from how do you build your implementation plan? How do you make sure that you don't feel overwhelmed and that you take a systematic approach that makes use of implementation science all the way through to retention? So with that, I will turn it back over to Lindsay. Thank you.
Thank you so much, Jessica. Let's turn now to our data corner, and I want to welcome Dr. Matthew Goldman to share with us. So, Matthew.
Thank you very much. Good to see everyone here today. We can go to the next slide. My comments will be brief. I just wanted to make people aware that the, I think, much anticipated National Survey of Mobile Crisis Teams has now, the report has now been posted to SAMHSA's website on their Technical Transfer Center website for crisis services. And so we're very excited that this information is now available to the public. It's a report that summarizes the findings of a survey that was conducted in early 2022 with over 550 mobile crisis programs responding to it, sharing information about their programs. And so direct you to that and encourage you to check out that new resource. Otherwise, just want to invite anybody who's interested in presenting at a data corner to reach out to me at my email address on the screen and in the chat. Thanks so much.
Wonderful. Thank you so much. All right, let's go to our federal updates and hear from Sarah at Guide Consulting. Sarah.
Thank you, Lindsay. So we can go to the next slide. While we focused a lot recently from the federal updates on wrapping up the FY24 process and what's to come with FY25, we thought we would take a quick look back at what is outstanding from the FY23 omnibus bill, which was signed into law at the end of December of 2022, if I'm getting the dates correct here. So a few of the provisions that are included, we've got over the next 3 slides in the non-appropriations portion of the bill, and a status update on each of those provisions. In the interest of time, I'm not going to go through each one in full detail. We've got the titles and the summaries as well, including expanding some of the telehealth flexibilities under Medicare, which is up for another extension by the end of this year. And that's something that Congress is currently working on, as well as something that ties in very well to our feature presentation today. The coverage of marriage and family therapists, as well as licensed mental health counselors under Medicare, that went live earlier this year. We can switch to the next slide. We've got a few more here, including the Medicare mobile crisis benefit, as well as partial hospitalization for intensive outpatient services that went into effect this year. And then, of course, we've got HHS collecting some data and revising Medicare payment system for inpatient psychiatric hospitals. That would go into effect next year. And we've got one more slide here. A couple of reports are outstanding. They have not been turned in yet, but we've got the due dates here listed on the status side, including HHS education, healthcare for healthcare providers and Medicare covered behavioral health integration services, a GAO study, and then last but not least, a forthcoming guidance from CMS on integrating, on payment for the crisis continuum at state level for CHIP and for Medicaid. That should be going live sometime before July 1st, 2025. So we're eagerly awaiting that guidance as well, but just wanted to kind of check in on where some of these outstanding matters are and what has gone live to date. If you've got any questions, please let me know. Thanks, Lindsay.
Thank you so much, Sarah. All right, now for our crisis talk, I want to welcome Stephanie Hepburn and Rachel Habacost to share with us today. So Stephanie, you want to tell us a little bit about your interview?
Yes, thanks, Lindsay. So yes, I would like to welcome author Rachel Habacost. We chatted about social media and mental health. Rachel, in January 2020, started a blog and a TikTok account. Can you talk a little bit about the impetus and what happened?
Yeah, thanks, Stephanie. So I was diagnosed with anorexia when I was 15. And at that time, mental health was incredibly stigmatized and social media did not exist. So I really thought that what I was struggling with was completely a personal problem and not something that other people experienced. And later in life, I went to group therapy and realized I wasn't alone. And so I made it my mission to try and help other people feel less alone through storytelling. And on January 1st, 2020, I decided I'm going to start a blog. I'm going to start posting on Instagram and TikTok. And very quickly, the pandemic came forward. I got divorced about a month later, and I sort of felt like this is now a space where I'm not only destigmatizing mental health, but I'm also processing grief and the resurgence of a lot of symptoms of my eating disorder and depression. And so it became a platform, not only for me to reduce my own shame through storytelling, but to connect with other people who were struggling in silence as well, and also start to destigmatize topics like eating disorders and suicidal depression that were really still not being spoken about. And it's been a really interesting landscape to navigate, specifically, and kind of also witnessing not only the destigmatization of mental health through these conversations and storytelling and safe spaces, but also to see how there's been an additional almost pain to profit model that's starting to happen, where people are preying on people's mental illnesses or mental health symptoms. And so it's a really delicate space that I still think we have a lot of work to do in trying to make sure that these spaces are still safe while we're still telling stories and helping people feel less alone, and making sure that we're using these spaces responsibly and ethically.
And I think one thing that I think is really interesting about what you talked about for the article is this intersection. So it was, I think the increase in usage was about 20% when it came to social media. 988 happened not too long after. And you talked about this intersection that you felt was a moment. And you talked about destigmatization, but can you talk a little bit about that moment?
Like the intersection between when people started to really be online and starting to talk about mental health. Yeah, I felt like that happened pretty quickly after the pandemic. When I started posting things on my Instagram, people really weren't talking about mental health at all. And suddenly, I think around like March, April, when people started being quarantined, everyone was online. I mean, people were just more naturally online. And not only that, but businesses started to have to figure out, how do we function digitally, which meant therapists and counselors were also starting to post things that they knew on social media as a way to connect with people, as a way to connect with clients, as a way to educate and advocate. And so there was an insurgence not only of people who were in the field of mental health and psychology providing information and resources. There was also a larger number of people who were just simply using and consuming social media. And so there was this intersection of consumption and creation. And not only that, people were struggling during the pandemic with loneliness, with grief, with loss, anxiety, with grief. And so I think that there was sort of this Venn diagram of the need, a sudden higher need for mental health care and support and education and advocacy, more creation from people in the field, and then just simply more consumption by nature of being at home and being online all the time.
Thank you so much for hopping on with me, Rachel. I appreciate it.
Thank you. Yeah,
I'll send it back to you, Lindsay.
Wonderful. And Rachel, thank you for all your work to destigmatize mental health and sharing your story and creating that space online. We want to preview, as we get to the end of our hour, what's upcoming in the Crisis Jam. Join us next week for our third Crisis Jam debate, where Vic Armstrong and David Covington will debate the use of the word emergency in crisis care and whether that is appropriate, helpful, not helpful. So it should be a lively and wonderful conversation, and Dr. Brian Sims is going to be moderating that. Next slide. And then in 2 weeks, you can join us to hear about co-response and safe stations from Jennifer Corbin and Lieutenant Steve Thomas. So be sure to mark your calendar for that conversation as well. So with that, thank you all so much for joining us for this week's edition of the Crisis Jam. Really appreciate the opportunity to be here with you all and to hear from the fabulous experts that shared today. And we will see you all same time, same place next week. Take care and be well. Bye.